Surgery of an aortic aneurysm with simultaneous reconstruction of the aortic valve. David operation. When the aortic valve ring is widened, the leaflets move away from each other, resulting in an insufficiency of the aortic valve with reverse flow. Reconstruction of aortic valve replacements are usually performed with a non-beating heart. After the chest is opened, the patient is connected to the heart and lung machine. The median sternotomy is the classical approach. For this purpose, the sternum is sawn lengthwise. The heart and lung machine is connected to the main aorta by way of tubing which delivers oxygen-enriched blood to the body. The venous return line is connected to the right atrium. When cardiopulmonary bypass is initiated, a clamp is placed on the main aorta and then under controlled conditions a potassium-rich solution is given which stops the heart. Thereafter, the surgeon resects the aortic root and the tissue in the area of the commissures, as well as coronary arteries, subsequently sutures, are placed under the valve and passed outside of the aortic annulus, the ring of tissue surrounding the valve. By tightening the sutures, the aorta prosthesis inverts over the valve ring. In the end, the prosthesis is sewn over the entire circumference. Since the prosthesis diameter is smaller than that of the valve ring, the leaflets are adapted and the valve competence is restored. After reconstruction is complete, the temporary pace wires are sewn to the heart and 2 to 3 thorax drainages are placed in the chest. The chest drainage tubes are removed on the 2nd and the pacemaker cable on the 5th day after surgery. The aortic cross clamp is opened, which perfuses the heart with warm blood, removing the effects of the cardioplegic solution. Cardiac activity is restored, allowing the termination of cardiopulmonary bypass. The sternum is then closed with sternal wires and the surgical wound with sutures. After surgery, the patient is transferred to the ICU.